So Sally, maybe you can go on to case 2 and tell us about this one.
Okay, so our next case is Dennis. And Dennis is a 65-year-old male. He's a former 2-pack-a-day smoker. He quit a year ago. And he sees his primary care physician because he's been complaining and experiencing a cough over the past month. A chest x-ray reveals that he has a poorly differentiated mass. It's confined to his upper right lobe. And a CT PET scan shows that he has a 4.5 by 2 centimeter tumor and possible intrapulmonary lymph node involvement. He does not have any evidence of distant metastases at this time. Surgical resection with mediastinal lymph node is performed. Histopathology confirms that he has a stage 2 non-small cell adenocarcinoma with negative surgical margins and no apparent involvement of his lymph nodes. After discussion of adjuvant chemotherapy options with the oncology team, a regimen of carboplatin and paclitaxel is selected. Although a cisplatin regimen would be a first choice for most patients at this stage, it is contraindicated in Dennis because he has moderate bilateral hearing impairment. So Dennis's chemotherapy schedule, again, he's going to be getting paclitaxel at a dose of 200 milligrams per meter squared. That's given over 3 hours, and carboplatin at an AUC of 6. This regimen is repeated every 21 days, and it's given for 4 cycles. So again, a fairly standard chemotherapy regimen for lung cancer and for many other cancers as well. So Dr. Schwartzberg, given Dennis's chemotherapy regimen of carboplatin and paclitaxel, what is his risk for chemotherapy-induced nausea and vomiting?
So we would go back to the chart and look at the individual drugs. And as we talked about already, paclitaxel is considered a low emetogenic risk. But carboplatin is characterized in the NCCN guidelines as in the moderate class. Now that moderate class, again, is a very broad range, which includes between a 30 to 90% risk of emesis. And we know that carboplatin actually sits at the top of this class, not that all that different from cisplatin. So in general, that's the type of patient that we would consider potentially for a 3-drug regimen. The guidelines give latitude here about whether to use a 2-drug antiemetic regimen or 3-drug antiemetic regimen for carboplatin containing regimens. Some of the guidelines, like the MASC-ESMO guidelines, have now identified carboplatin as a special category, somewhat analogous to the way AC moved up to highly emetogenic, and that carboplatin should be considered for a more intensive antiemetic regimen like the highly emetogenic chemotherapy drugs.
So what risk factors might make you, other than the carboplatin, what other risk factors might Dennis have that might make you make changes to his antiemetic regimen?
So if in Dennis's case, as you mentioned, age and gender are very important. So he doesn't meet the criteria there to be in the highest risk of from patient risk factor perspective. But if he had no alcohol use, if he had a history of emesis with other drugs, if he had motion sickness, those would also shade me into considering a more highly emetogenic regimen. Although again, even without these risk factors for carboplatin in particular, I would consider using a 3-drug regimen. I find that the risk factors are particularly good for patients who are maybe in a category just below that, like an oxaliplatin containing regimen, and there the risk factors are very important to make a decision to start with a more intensive antiemetic regimen. So
it sounds like you might have alluded to this already, but just specifically, so what first-line guideline-recommended regimen would you use? One that contains an NK1 antagonist, or have you used perhaps an olanzapine regimen in a patient like this?
So typically, if I'm going to use a 2-drug antiemetic regimen here, as per guideline, I will use palinositron and dexamethasone. And that's because clinical trials have shown that palinositron in a doublet regimen, that palinositron and dexamethasone is superior to the first generation 5-HT3 receptor antagonist and dexamethasone. When we add the NK1 We don't have information that one 5-HT3RA is better than the other. We're adding a new class of drugs. So probably I would use a combination, and I would still use palonosetron because it's long-acting palonosetron, an NK1 antagonist, and dexamethasone in this particular case. However, one could use NEPA as an alternative. Again, fixed dose of nitupidine and palonosetron. One could use rolapitant or fosaprepitant or aprepitant as the NK1 antagonist, or one could use olanzapine instead of the NK1. Yeah, in my own practice, I'm using olanzapine in two instances. One, to add on if a patient does have breakthrough in a previous cycle, even though I've given a 3-drug regimen. Or now with the publication of a randomized trial of 4 drugs versus 3, I think there will be some movement in patients who we think are at very high risk, who are receiving AC, who are getting a 3-drug regimen. And this would be the patient, Sally, that you mentioned. So young female patients with a history of hyperemesis of pregnancy or car sickness. Those are the patients I'm definitely going to give a 4-drug prophylactic regimen to in the future. So let's say that Dennis experienced CINV during his first round of chemotherapy, even though we gave a regimen. What would you do in the next round, Sally?
So again, I think we have several different options, so it would depend on what we gave in the first round as to how we might change things for subsequent cycles of chemotherapy. Again, I go back to, it's important to talk to the patient. When did they have nausea and vomiting? Was it the day of chemotherapy? Was it 3 days after? Understanding what were they given to take on a scheduled basis or on an as-needed basis with his chemotherapy, and did he take it? I think it's important to, sometimes people just knee-jerk call in a prescription for something. I think it's important to make sure we talk to dentists or whoever the patient may be and find out exactly what they experienced, when they experienced, and what drugs they had and whether or not they took them. So if Dennis had been given 5-HT3 antagonist plus dexamethasone and had delayed emesis despite that, as you've sort of alluded to, there's several different options. One, adding an NK1 antagonist. That's typically what would happen here at our practice, is we would add that if we hadn't added it already. Looking at if they had taken breakthrough medication and if it had or hadn't worked, making a change there. You alluded to adding olanzapine if an NK1 antagonist had already been on board, adding a drug. I think the important thing is to add drugs that have a different mechanism of action. Sometimes folks have a tendency to just want to give more of what they've already given, and usually the doses that they've been given at, we know, are doses where they're maximally effective, so just giving more doesn't really help. So real important to make sure that you're looking at all the different drugs, the dopamine antagonists, other drugs that are available that might offer some benefit because they have a different mechanism of action. So I think there's a lot of options. Again, just in this case, if he had just gotten a 5-HT3 antagonist and dexamethasone, we would probably add an NK1 antagonist. If he'd had prolonged delayed emesis, we might extend the dex a little bit. I think there's a couple different options.
Great, I agree completely. Can you comment on some of the other kinds of situations that we deal with frequently in our clinics, multi-day chemotherapy and how to use antiemetics there? Or increasingly, we're seeing new oral medications, some of which are at least moderately emetogenic. How should we address these types of patients? Yeah,
those are two situations that are probably some of our, in addition to just nausea, some of our bigger challenges, because we just don't have the guidelines might not address them, or they address them with limited amount of data to support them. So specifically with multi-day chemotherapy, still the basic tenets of prevention of nausea and vomiting, would prevail here. So making sure that each day of a multi-day chemotherapy, whether it's 3 days or 5 days, that the patient is receiving prophylactic antiemetics that match the emetogenicity of the agent they're giving. But also what complicates this is that oftentimes or sometimes, patients are getting chemotherapy drugs that have a delayed emesis component with with drugs that might be low emetogenicity, but there's delayed on top of it. So it's trying to predict and manage the acute and the delayed when they're overlapping each other. So again, making sure that they're receiving antiemetics on the days of chemotherapy that match that risk, and really looking at the other risk factors. And really in this case, it is important to look at all the chemotherapy and what days they're getting it and matching it to that. And then I think, usually, although not all the time, but you're seeing patients, whether they're inpatient or outpatient, you're seeing them every day that they're getting this chemotherapy. I think it goes back to the importance of continual reassessment. If you have a patient that, let's say, is getting cisplatin and etoposide for 5 days, checking, having the infusion nurse check in with them on day 2 and day 3. Are you having any issues, so that you can, make changes and address it while they're there. So I know that the guidelines, address this, but it's more, they're not specific recommendations, and that's because the guidelines are based off of, studies that looked at single day chemotherapy being administered on one day. So we just don't have a lot of the data. So that's how we approach multi-day chemotherapy. Oral chemotherapy is another challenge. Obviously, there's been a significant growth in the utilization of these agents in a variety of different tumor types. In general, I would say most of them fall into the lower category, but again, there are those that fall into a more moderate, and patients do need something prophylactically. It's hard because oftentimes patients are taking these drugs every day, sometimes twice a day. So at least the NCCN guidelines have tried to address and categorize these drugs into sort of 2 categories of a low to minimal, where you could just give someone, make sure they have something to use as needed. And then drugs like crizotinib and some of the other drugs that are more moderate. So we, at least in those instances, will have patients take something prophylactically and then sort of see how it goes. Because sometimes, it causes nausea when they begin to take it, but then it will sometimes ease off a little bit. So that's been our approach. Do you have any, what are your thoughts on those 2 scenarios?
No, I agree. I agree completely. And I think the orals still need to be worked out, but you're right. There's only a few drugs that are moderately emetogenic, and sometimes giving 5-HT3 orally and then to use as needed after the first few days and see what happens, I think is exactly the right strategy.
So another scenario, a lot of times patients are also getting concurrent radiation with chemotherapy. Do you have a different approach, or what is your approach to manage nausea and vomiting in patients who might be getting concurrent radiation with their chemotherapy?
So this is another area where there's not as much data as we would like. We do know that radiation by itself can be characterized for its emetogenicity based on where you're radiating. So lower abdominal pelvic tends to have a higher, or a higher abdominal tends to have a higher risk of getting nausea and vomiting. No surprise, because the GI tract is in that. Less so for thoracic radiation and pelvic radiation per se, although pelvic itself still does have a risk. And total body radiation, which is used predominantly in bone marrow transplant, has a very high risk of nausea and vomiting. So that's sort of the baseline. And then if you add on the chemotherapy, we'd use the same principles as we would for chemotherapy. In gynecologic patients, there is frequently a weekly cisplatin dose added to radiation, and those patients may be at extremely high risk, highly emetogenic risk between their radiation and their chemo. And there's been some recent work which suggests that a triplet regimen given weekly, NK1, 5-HT3, and dexamethasone, can help alleviate the chronic nausea and vomiting that occurs over a 5 to 6 week period of combined chemo radiation. So we hope to see more around that. But I've gotten more aggressive in my anti-emesis for patients who are receiving that kind of treatment because of the data now. So we've had a nice discussion, and I think we can wrap up now with a few conclusions. And number one, the most important point, what we'd like to do with CINV is prevent it, not have to treat it. And we're talking about giving prophylaxis before the first cycle and every cycle of chemotherapy based on the degree of emetogenicity of the regimen and the patient risk factors. The choices of preventative agents are increasing. We have new drugs that have been approved over the last couple of years. We have the old stalwarts over the last couple of decades, which have fundamentally changed our approach and the chance of a patient getting nausea and vomiting, although it's not always recognized out in the community that we've done much better than we did before. The selection of preventative agents and any further intervention, if needed, should absolutely involve all members of the team. The multidisciplinary team is the way we treat patients today. Every member has great value in adding to that team. Pharmacists in particular, when it comes to CINV, are invaluable from many dimensions in terms of patient interactions and also helping manage interactions between the drugs that patients take. And I think it's fair to say we're optimistic that we're making progress year over year now in terms of preventing CINV, and our ultimate goal is hopefully at hand.